What I'd like to do now is just welcome Dr. Scott. Dr. Scott's been practicing with us for, I'd say, since October of last year?
October, yep.
Since October of last year. And every patient that I have encountered that he has loved what he provides here for the community. Something that is unique to his service is he actually came here to practice in our pain management clinic as part of a comprehensive pain program. But we actually lost one of our key physicians for that, and so we're actually looking for another physician that's going to be working with Dr. Scott and providing that comprehensive pain program for our community. And one other thing I should notice or mention about that is he takes all insurances, which not all chiropractors in our community actually do. Which is a great thing for people that are on Medicaid or have Medicare. He's able to take all of those insurances. Some of the other chiropractors in the community are a little bit more selective in what they are able to take just because they don't have the ability to take some of those insurances. So please join me in welcoming Dr. Scott.
Thank you. Thanks for the intro, Nick. So I want to also give thanks to the hospital for letting me put this presentation on. Tonight I plan on educating you a little bit about who I am, where I'm from, what I've studied, the conditions that I treat every day, and on top of that I'm going to provide a little bit more education about them, and then I'm going to also put on a mock treatment presentation for anybody that's unfamiliar with what chiropractic work looks like or some of the things that we offer. I'm going to show you what it looks like today. So let's get started. And so right off, like Nick said, I am a Hermiston native. I grew up here in Hermiston, Oregon. I graduated from Hermiston High School in 2003. In 2009, I graduated from Eastern Oregon University. My first bachelor degree was in accounting. I spent a little bit of time doing accounting work. After a short amount of time, I decided I wanted to go back. I wanted to study medicine, and decided that chiropractic care was what I wanted to go into. I fell in love with it and really appreciate it for what it was. So in 2014, I enrolled in graduate school. Started at the University of Western States. In 2015, throughout some of my coursework, I ended up earning another bachelor degree, except this time it was in human biology. And then halfway through my doctorate chiropractic work, I decided that I actually wanted to start studying a little bit more stuff, and so I enrolled in a master's of sports medicine. 2017, by the time I graduated with my doctorate in chiropractic degree, I was also able to graduate with a master's degree in sports medicine. And I can take both of those worlds and kind of combine them together and have a really great approach to treating people. And then, as like Nick said, October 2017, I started working here at Good Shepherd. So what is a chiropractor? Some people usually have questions or not quite sure exactly what we do. And the best definition that I could come up with was that I'm a conservative orthopedist. I have an emphasis on diagnosing, treating, and preventing conditions that are related to the neuromusculoskeletal system. So that involves things like the nerves, the bones, joints, muscles, ligaments, tendons, the spine, of course, always, and extremities, so the arms and the legs and things like that. So education and curriculum, what does it take to become a chiropractor? It takes a lot of school. You're going to be in college for quite a while. There's a lot of work that goes into it. First off, you got to get an undergraduate degree, and it's usually in along the lines of the science studies, pre-medicine type of work. After that's accomplished and you apply for graduate school, chiropractic school is a 4-year doctorate work on top of your previous undergrad. So then the 4 years of study, the first 2 years of study are going to be basic graduate medical science work. So you'll be learning things like gross anatomy, spinal anatomy, physiology, microbiology, chemistry, biochemistry, pathology, things of that nature. And then the last 2 years of work, it's going to be a mixture between clinical internship, where you're actually working on patients, and then a mixture of other graduate medical classes on top of that. And then at the end of all of it, you can enroll into a 3-month preceptorship before you go on out and get licensed. To get licensed is quite a challenge too. You have to endure through 15 national board exams. And depending upon what state you practice in the state of Oregon, there was 3 different licensing exams that you all had to pass. And if you're able to get through all that, they're going to give you a license and say congratulations. So the things that I treat a lot of different stuff, and it's kind of hard to go through this entire list. It's probably not worth reading through all of it, but this is a quick kind of dirty list of all the things that I may see in one day. There's obviously some things that I see more than others, and if we break that down a little bit more, what I see on average, mostly day in and day out, I see low back pain. I can be sure that every other person that comes through my door is going to have low back pain right here in this region. Neck pain is another big one too. Probably not quite as common as the low back pain is, but neck pain it's right up there also. And then I see a lot of injuries too, sports related, work injuries, overstrain, things like that. But you better be sure that low back pain is what's coming through the door mostly every single day. So some common causes of low back pain. Right off the bat, we're looking at things like sprains and strains of the ligaments, the tissues, the tendons, the muscles. Again, like sports related work. People can have degenerating disc syndromes where the bones are starting to change shape a little bit. Herniated disc, we're talking things like radiculopathy, sciatica. I'm sure that's a term you've all heard plenty of times. Spondylolisthesis, which is a kind of a bad one, but that's a fracture of the vertebrae in a certain area. Traumatic injuries, stenosis, which is just kind of a bony buildup of where the nerves come out of around the spine. And anatomical irregularities. We're talking things like scoliosis, for example. This picture right here, I really like this picture. This is a disc. If you were to look down, kind of what they would say, like if you cut a disc in half and weren't able to look at it, this is a disc that is starting to tear, the fibers on the outside. And so we call these the reticular fibers, and they're starting to tear. And most likely what happens is that this disc started to tear right here in the center, because all disc tears that we know, according to research, start inside the center, and it's worked its way out. And we can tell that this disc is starting to repair itself because we can see more blood flow starting to come back inside the disc in attempts to try to heal it. We know this is happening because discs are avascular and they're mostly aneural, meaning that there's not a lot of blood supply or nerve supply to a disc. So if we see this going on, we know that this is an old injury and it's trying to repair itself. And this person is most likely suffering from what we call a radiculopathy, where this disc is herniated through and it's pinching on the nerves out the spine, which will cause like a lot of symptoms into like the legs, like numbness, tingling, or weakness, stuff like that. So next, what are some risk factors involved with low back pain? Well, we got Mike Rowe here, and I thought this is a good example. So occupational work risk. We see a lot of blue collar workers that are bending over and picking up heavy equipment all day long. They tend to wear out the disc. Maybe they got bad movement patterns. And so they're not, what I would say, they're moving incorrectly. So people like that, they're going to have a lot of risk factors for low back pain. Age is another big one, believe it or not. The older population, more times than not, are safer, will not have as much low back pain. The older you get, the more stiff the spine is going to become. The ligaments and the tissues, the soft tissues, they will start to harden up. The disc doesn't hold as much water as it did when you were younger, and so it's just stiffer all around. So there's just less of a chance to have low back pain. Younger people generally have more back pain than the olders do. Fitness level, that's a really big one. Research has shown over and over again that the more physically active and fit you are, the more the less chance you're going to have to having low back pain. So I'm going to recommend everybody that comes into the office exercise, and exercise a lot. It's really important. Pregnancy, we see a lot of women with low back pain that are pregnant. Weight gain is another really big risk factor, and usually the reason this is because those with increased weight gain tend to be not the most fit individuals. The muscles don't have as much strength, as much endurance. And on top of that, just the extra weight is hard for the spine to carry that type of load, and it usually carries it incorrectly. So we try and tell people, and along with fitness level, we try to maintain your weight gain also. Genetics plays a big role too. Some people in life are just dealt a poor card when it comes to genetic health. So we do what we can to help serve that. Poor mental health. This one right here is huge, and I'm going to explain why later in this presentation, why poor mental health plays a very large factor in low back pain. It's going to tie into the opioid epidemic that's been going on in America. And overloaded backpacks. I thought this one was pretty cute, but studies do show that kids that go to school with too much weight in the backpacks have shown to have certain spinal fractures. Not all the time, but it does happen. So some facts on low back pain. Low back pain is the leading worldwide cause of years lost to disability. Back pain is one of the most common reasons for missed work. In fact, it's the second most common reason for trips to the doctor's office. It's only second to upper respiratory infections. And according to a study down here, it's estimated that 80% of people will experience at least one episode of debilitating back pain in their lifetime. So what does low back pain cost? It does have a financial burden on America. In 2008, the Spine Journal released a systematic review and a nerd data analysis and pooling of all the studies that have been accumulated through the years. They determined that the total direct and indirect cost of low back pain in America on average is between 84 billion and 624 billion. Now I realize that's a really wide set of numbers, but if we take a conservative approach to it and we take the median of it, we come up with $354 billion, which is a ton of money. And so a little perspective on just how much that really is. In 2016, cardiovascular disease cost more money than any other health problem, and it costs over $500 billion, $555 billion. Diabetes is another big one, but it costs $327 billion. And then we look down, according to the American Cancer Society, their website, almost $88 billion was spent on treating cancer in America in 2014. So I'm going to put this into a graph for you because it gives it a little bit more of an idea just exactly what the numbers are. So here's, I just kind of cut off down here, I'm sorry that you can't read that, but heart disease right here again, $555 billion. We go back down here to low back pain, right up here in the mid $300 billion. Down here we are with cancer at about 88, and we're at 327 back here with diabetes. So that kind of gives you some perspective. You know, most people wouldn't have ever thought that low back pain would cost you so much money, but it does because it's very debilitating. Like I said in the previous slide, you know, it's the leading cause of disability, and people don't go back to work until there's lost wages and then all the medical expenses that are associated with it. So, like I stated a couple slides ago, mental health is extremely important when it comes to managing low back pain because it ties in with the opioid epidemic. And like I said, I'm going to discuss that and why that is. But I'd like to discuss a couple studies that say why this is. A study produced by the American Journal of Psychiatry focused on 13,089 opioid-related deaths in the Medicaid population. Of that 13,000 deaths, 61.5% were diagnosed with chronic pain conditions. Of that same population, almost 60% of them was diagnosed with low back pain. In their last 12 months of life, that chronic pain population was more likely to receive a mental health diagnosis. We're talking things like depression and anxiety, things of the sort, when compared to the non-pain population. The conclusions of that study were that people that died of opioid-related causes, particularly those that were diagnosed with chronic pain conditions, commonly received services related to drug use disorders and mental health disorders in the last years of life. So the big takeaway is that clinicians need to exercise a lot of caution when prescribing benzodiazepines. Right. And so into the next one here, the Journal of American Board of Family Medicine, they state that the majority of opioid scripts will go to patients with mental health disorders. In America, 60% of its population is diagnosed with a mental health disorder. Again, stress, anxiety, and depression. That 60% of Americans received 51.4% of all opioid prescriptions. So clinicians who provide care for this population need to be aware of the increased rate of opioid use and be able to implement non-opioid related therapies when appropriate. That's exactly what I do. Spinal manipulation, exercise, and everything else. That's me right there. So another one by the International Association for the Study of Pain. The analysis of a nationwide sample of people with low back pain shows an association between depression and higher rates of opioid prescribing. There's a strong association between depressive symptoms and opioid use for low back pain. And the reason is because of that all their studies have proven that people that have these mental health disorders, that the opioid drugs have a reduced analgesic effect on pain, which means that they don't work as good at reducing the low back pain. And so therefore they have to take increased amounts just to get that same effect than what somebody that would not have a mental health disorder is. So when they're increasing all these drug uses, that's where the side effects and these deaths are coming from. Another one here was another study examined whether the prevalence of unhealthy lifestyles, psychological distress, and healthcare utilization for prescribing sedative hypnotics was increased duration of opioid use. And this study was showing that, once again, that exercise was extremely important and extremely beneficial for helping mental health. And when we were able to manage the mental health, it was also, like what I stated just a minute ago, the people didn't have to rely so much on opioid use, and they were able to decrease their opioid use. It's averaged right now in America, about 144 people are dying every day of opioid overdoses. And so that's a pretty astounding number, and that needs to be really taken care of in America. OHSU released a study that was used to serve as the current guideline for physicians when referring to alternative medical providers, non-pharmacologic, that is, when managing low back pain. Their evidence continues to support the effectiveness of exercise, psychological therapies, multidisciplinary rehab, and spinal manipulation. Right, again, that's exactly everything, all the services that I offer. So at this point, I kind of like to show you exactly what it is that I do on average when I see the patient, because like I said earlier, a lot of people haven't been to the chiropractor and they don't know what they do. So I got a volunteer that's going to help me out. Everybody say hi to Lane. So just like I stated earlier, Lane, told me earlier that he does in fact have some neck pain and he's got some low back pain. And Lane likes to work out quite a bit. He's a pretty active type of guy. He likes to ride a lot of mountain bikes, running, biking, lifting, that whole thing. So frequently, he's a little sore. He's a little beat up. And so before I would ever do any sort of treatment or anything for him, first thing that we're going to do, we're going to grab a medical history on Lane. And it's going to be composed of things like, we've got to get his family history. We got to know if his family's got if there's a history of heart disease or anything that goes on with them. We're also going to get a social and a past family history health on them. After that's been determined and read through, then we would conduct a physical exam. And so at this point, we're going to dive in and tease apart what's going on in the body to figure out if we can figure out what's going on with them. We're going to check ranges of motion, orthopedic tests to determine if he does have pinched nerves or whatever else is going on with his body. Muscular tests and other neurological tests to make sure that something really serious isn't going on. And if we really need to dig a little deeper, we can grab imaging and labs. Here at the hospital, we can get X-ray, MRI, CT scans, whatever kind of imaging we need to do, we can all do it right here in the hospital. Which is another great reason to have a chiropractor here in the hospital, because it's a full meal deal. We got everything you need. So there's a lot of different ways that I can provide treatment also. The most common thing that people think of is manipulative therapy. So CMT is what we call that. Also, another big one, and I use every single day, and I like this because it has a lot of benefit to patients, is what we call directional preference, or McKinsey protocols. And this is when I use repeated movements and sustained over postures to elicit centralization of radicular symptoms. It's really fancy sounding, I understand that. So what that means is if Lane's got like a disc herniation, and he says, hey, I got a lot of numbness and tingling and pins and needles into my foot. Instead of adjusting them, what we do is that we can manipulate the spine in certain ways, and that we can kind of take the pressure off of this disc bulge or this herniation and take the pressure off the nerves, and so he doesn't feel everything going down inside his foot anymore, and so his back will start to hurt less also. After we've done those first two things, then we kind of go into a biomechanical assessment and re-education. This is where I'm teaching them how to move better. A lot of people, for example, have a lot of back pain when they bend over to pick up their children off the ground, or they're bending over to wash dishes, things like that. And so this is the part where we show them how not to bend the back, but instead maybe how to move with the hips. After those have been taught and provided, then we're going to start going into rehab exercises. And this becomes a really big one, because this right here is what's going to provide a lot of long-term resilience for patients. This is where we're going to teach them how to build proper core strength, how to build proper movement patterns, the things that they need for future resilience. And if they've got let's say like soft tissue problems going on. They got muscles that have been hurt from whatever reason. There's a lot of things we can provide, like ART, MET, which is a fancy way of stretching. There's trigger point release, there's cupping and mobilization therapies. And then we can also give your typical physical therapy modalities like ice, laser, ultrasound, heat, taping, things like that. So some of the goals of treatment is that when a patient comes in, obviously they say, hey, I want my pain to go away. But beyond that, we got to have more measures into what we can objectify the outcome for. Another big one is increasing their activities of daily life. This means like frequently patients will say to me, I can't bend over and pick up my kids anymore, or I can't play with my grandchildren, I can't wash the dishes. And so we base this on a grading system. How well can you perform this activity now? We may not always be able to get rid of all the pain, but we can increase their ability to do the activities that they need to do in everyday life to get on to the next day. Also, we want to be able to hopefully increase his mobility. He may be stiff and sore from getting hurt. Hopefully we can increase his range of motion. We want to be able to stabilize that spine. Also, increase motor control. How well can he control his movements? And obviously strength, like I said. So, Lane, you ready?
Ready.
All right. So, as stated earlier, he's a little bit sore, he's a little bit stiff, and so what I'll have him do is I'm going to work on his mid-back first, and so what I'll have you do, Lane, is lay face down into the table for me, please. And before we go into play any sort of therapy, we're going to check out, see what he's got going on. How well is his spine moving? How stiff is he? How good does he feel? And he's got a lot of stiffness in his mid-back. So what I'm going to have him do is have Lane take a big breath in for me, and let it all out, and I'm just going to apply a little push to his mid-back. Take a breath in again, and let it out. Good. Flip over into your back for me. Usually I'll work with the mid-back, work my way up to the neck. Get your head up for me. There you go. Before we make an adjustment, like I said, we got to feel around, see what's going on inside the joints. Make sure that it doesn't hurt them. All right, so take a big breath in for me, and then let it all out. There you go. They're liking it. All right, take a breath in again, and let it out. Feeling okay?
Doing good.
All right, good. Lay on your side toward me. We'll get this lumbar adjusted for you. So we're gonna make that bottom leg straight. You're gonna tuck this top one. There you go. Give me your elbow, relax right here. Thank you. So take a big breath in, and I want you to look out over toward the door and let that back spin for me. There you go, good. To the other side. Breath in and out again. Good. Come on up. How you feel?
Fantastic.
Like $1 million bucks?
Like $1 million.
Attaboy.
That's the script. How much did you pay him?
He's a great patient, isn't he?
Would you have done imaging before you did any of that?
Depends on what the exam showed. If he had indications that said, yeah, he does need imaging, yeah, we'd definitely get him. Sometimes patients come in, and like I said, they got like disc herniation symptoms where they got numbness and tingling. A lot of cases, yeah, we're going to get an MRI on them to see what's going on. And if needs be, we're going to refer out to a different doctor that needs that would better handle him, like a neurosurgeon or somebody else.
Do people sometimes have more pain after manipulation?
Generally not, no. Sometimes it can. Sometimes what will happen is that we'll give the warning that sometimes after treatment you may feel a little bit of residual soreness, kind of like you hadn't worked out in a while. That short-term kind of delayed muscle soreness you get, but it usually goes away really quick within 24 hours, and it's very rare when people get that in general anyways. Yeah. So, now that Lane feels good, he doesn't want to always have to keep coming back into the doctor's office. We're always here for him when he needs us, but what can he do to keep himself, prevent further problems happening? So like I stated earlier, proper movement patterns. Stop bending over all the time to pick your kids up with a rounded back. We're going to teach them how to move through the hips and brace with the spine and the core. Proper core strengthening, like I just said. Minimize the risk factors. From one of the earlier slides I talked about, we're going to try and minimize all those things that we can control. If he's got a previous injury, we want to make sure that we rehab that thing perfectly before we jump into the next thing, because we don't want an old injury biting us in the butt later. And then psychological analysis. If there is in fact a mental health problem that's going on, we need to get that addressed, because you're going to fight that and it's going to really slow down the prognosis. And last but not least, remember this slide, exercise. For goodness sakes, never stop exercising. It's more important than you'll ever understand. And lastly, the convenience of having a chiropractor here at the office, within the hospital. We're going to show a willingness to collaborate with other healthcare professionals to improve outcomes and reduce the cost for all patients. And like I said again, we have all the other health departments here in the hospital within close proximity. We got imaging, orthopedics, your primary care physicians. It's all right here. It's a one-stop shop. So we can provide a lot for you. And so I really appreciate everybody coming out here today and listening to me. Hopefully you got some good education on what's going on with me and the services that I offer. And thank you very much. If anybody's got any questions, I'd like to hear them.
So what kind of exercises would you give to Lane to demonstrate, as far as what somebody should do if they're having low back pain and you just adjust them and they go home? Mm-hmm. What would your recommendation be?
So based off of what the number one way that I would do this is, I'm going to establish what is causing this pain. Let's take spinal flexion. If, like I stated a little bit ago, if bending over and picking up his kids are causing pain, then we need to prevent him going into spinal flexion, and we want to create movement through our hips rather than our low back. So at that point, we're going to stabilize the spine to make sure that when he does make a correct movement, that the spine isn't going to move with it. And so we're going to work on those specific exercises that improve that movement quality, if that makes sense.
What does that look like?
Would you like to see one of those? Want to help me?
Sure.
All right.
We're done.
Yeah, so that'd be great. So a lot of times people have spinal instability, which causes a lot of pain. And so what we try to do for him is that I want to create a rigid cylinder within his abdominal region. And one of the best exercises that we can do is called the bird dog. And the way that we do this is that I'm going to tell Lane to look up just a little bit, and he's going to tighten up his entire core system right here. He's going to imagine that I'm going to come up here and try to smack him in the belly. Instinctively, he's going to tighten his entire core so that it doesn't hurt. So with a braced core, he's going to raise one arm out like that, and then he's going to donkey kick his opposite leg backwards just like this. And he's going to hold this here for 10 seconds. And what this does is that it's going to tighten up all these muscles back here, and up here. And then he can relax, come in, and then he can use his other opposite arm and leg and hold it just like that. And Lane's doing a really good job of this, because you can see that he's not rotating his hips when he puts his arm and leg out there. That's bad. We don't want that. He just dipped his entire pelvis. That defeats the entire purpose of this exercise. Show him a good one.
Good one?
Good one. Textbook. That's how it's done. That's obviously an advanced movement. Depending on people's level of physicality, we can start at the basic building blocks of that. We can do like wall variations of it too. So,
Okay.
Yep.
Thank you.
You bet. Are there any other questions?
When people come in with all different various problems, and you're going to kind of diagnose them,
Sure.
if they might need MRIs or whatever before you go ahead with your procedure or whatever. But do you have the knowledge, but do you explain it to the patient?
Oh yeah, sure.
So they understand what's happened to
Yeah.
them?
Are you asking, they want to understand what exactly, they want to have they want a mental image of what's going on. Yeah, and I'm going to always explain it to the best of my ability so that they understand what's going on because it helps relieve a lot of anxiety and questions about what's going on. So yeah, I will always explain things to people the entire time. And if I can, I'll try and bring out a like a picture or some type of quick video or something. So yeah.
If I come in for the first time with some issues, how long do you spend with me?
So the very first visit, all new patients get 1 hour on new patient visits, because we're going to do an exam and we're going to do a treatment on top of that. And then after I get to know you personally, we've established a relationship. At that point, most return visits are going to be half hour in length. That's about all that we need for a day of treatment.
Where's your office? Where are you located?
All the way in the back of the hospital at the Good Shepherd Medical Group. It's kind of down by pediatrics. Yep, so just if you walk through this hallway, all the way down. Anybody else?
Cost per hour.
They know all the way up there in the office. Anybody else? No? Okay. Hey, yeah.
So that was a good question, because you do, if somebody chooses not to use their insurance, you can charge by the hour, correct?
I do believe so. Yeah, there are
They actually
predetermined
have
rates.
that worked out in the front office, yeah.
Yep. So, if there isn't anything else, like I said, I really appreciate everyone coming out here and listening to what I had to say. Thank you very much.